Hello everyone. In this session, we are going to discuss a very important topic, that is testicular tumors. So usually in your university exams, you get a long question on that. If you're getting a long question, you have to write everything about it, including its classification, its etiology, clinical features, spread, gross and microscopy of all types of testicular tumor, the important types of testicular tumor. But sometimes you can get a short question on any one of them, maybe on Seminoma, Yolk Sac Tumor or Teratoma. So we will see these three in detail also, and we will see completely all about testicular tumors. So let's start the topic, testicular tumors. So here you can see we are starting the topic, that is testicular tumors. It's very important topic from university exam point of view. So first of all, I will let you know the two type of classification of testicular tumor. I will let you know the two type of classification. First pathological classification, then clinical classification. So in your exam, you have to write both type of classification. Then we will see the risk factor, the etiological factors for the testicular tumors. Then we will see the clinical features and the spread. So etiological factors, clinical features and spread are common for all type of testicular tumors, whatever we will see in the classification. Among the classification, three are ultra important. So we will see three in detail. Which three? Seminoma, Yolk Sac Tumor and Teratoma. These three are very important. So usually in your university exam, the separate short question may come on any three or one of them out of these three. So you have to understand the gross and microscopy and tumor markers of all these three. So we will make a comparative table between the three. So let's start it, the topic testicular tumor. So first of all, let's see the classification of the testicular tumor. So we will discuss the two type of classification of testicular tumor, the pathological classification and the clinical classification. So this is the pathological classification. Now the testicular tumors, it can arise from the germ cell. So these are known as germ cell tumors. These are known as GCTs. They are arising from the germ cell tumors. They can arise from the sex cord stroma. So these are known as sex cord stromal tumors if they are arising from the stroma, and sometimes they can be combined. I hope you all know the histology of normal testes. In the histology of the normal testes, you can see how many type of cells are present. You can see these are the seminiferous tubules. So you can appreciate these are the seminiferous tubules containing the germ cells inside them. So if the tumor is arising from these germ cell, you can see these are the germ cells. So if the tumor is arising from these germ cell, it is known as germ cell tumor, GCT. And if the tumor is arising from the stroma, you can see the background stroma and the cells in the stroma. So these are known as sex cord tumors. So these are two main type of tumors present in the testes. Germ cell tumors arising from the germ cell and the sex cord stromal tumors, they arise from the stroma. So how many germ cell tumors are there? There are 6 germ cell tumor. I'm having a mnemonic to learn that. The mnemonic is YESPCT. Y stand for Yolk Sac, E stand for embryonal carcinoma, S stand for seminoma, P stand for polyembryoma, C stand for choriocarcinoma and T stand for teratoma. So these are the 6 germ cell tumors. Sex cord tumor, they are 3 in number. The mnemonic is LSG. L for Leydig cell tumor, S is Sertoli and G is granulosa. And the combined one is gonadoblastoma, which is not very important. Okay, so how many type of testicular tumors are there? So tell me the pathologic classification. So we will see the clinical classification after this. First, you tell me the pathological classification of the testicular tumors. There are 3 type of testicular tumors. The one which arise from the germ cell are known as germ cell tumors, GCTs. The one which arise from the stroma are known as sex cord stromal tumors. And the third one are the combined. You can see. So GCT, there are 6 GCT number. How many GCTs? There are 6 GCT. What is the mnemonic? The mnemonic is YESPCT. YESPCT. And how many sex cord stromal tumors? There are 3 sex cord stromal tumors. The mnemonic is LSG. And combined is only one, that is gonadoblastoma. So say the full form of YESPCT. Yolk Sac tumor, embryoma, seminoma, polyembryoma, choriocarcinoma and teratoma. So out of these, 3 are ultra important that I will discuss in detail. That is Yolk Sac, seminoma and teratoma. Yolk Sac, seminoma and teratoma we will see in detail. Among the sex cord, there are 3 sex cord: Leydig cell, Sertoli cell and granulosa. You just learn the name. Nobody is going to ask you the details separately. And the combined is gonadoblastoma. So we will see the 3 details of out of the 6, the 3 germ cell tumor in detail. We will see. Now before that, let me tell you the clinical classification of testicular tumor. We have already seen the pathological classification of testicular tumor. Now coming on the clinical classification. So how to divide them clinically? So we divide them into 2 categories: the germ cell, the non-germ cell. The non-germ cell are the sex cord stromal tumor, that is LSG. Leydig cell, Sertoli cell and granulosa cell, that is LSG. These are the stromal tumors. Among the germ cell, how many type of germ cell tumors are there? YESPCT, the 6. We are separating seminoma from all others. because the prognosis and treatment of seminoma is different from all others. So separate the seminoma and the remaining 5. What are the remaining 5? YE, there is no S, PCT. So the remaining 5 are on one side and the seminoma is on one side. So we are dividing them in 2 categories. So seminoma is known as seminomatous germ cell tumor and the remaining 5 are known as non-seminomatous germ cell tumor. You got it? So out of the 6 germ cell tumor, what are the 6 germ cell tumor? YES, PCT, we are dividing them into 2 categories. One is seminomatous germ cell tumor and one is non-seminomatous germ cell tumor. Non-seminomatous germ cell tumor. These are known as seminomatous germ cell tumor means SGCT and these are non-seminomatous germ cell tumor NSGCT. So that is the full form. Okay. Now what does they contain? Seminomatous germ cell tumor contain only one thing, seminoma. That's it. So out of the 6, seminoma is coming here. And the non-seminomatous germ cell tumor NSGCT contain the remaining 5, YEPCT. So YEPCT will come here. Okay. So why we are separating this clinically? Because clinically, seminoma have different treatment and different prognosis. The treatment, it is very radiosensitive. So we give radiotherapy as treatment. These are non-radiosensitive. These are radio-resistant. So here surgical treatment is the main treatment. So here these are radiosensitive. We give radiotherapy. These are radio resistant, so we do the surgery. Here prognosis is very good and spread is very late. Metastatic spread is very late. And here the prognosis is poor because spread is very fast. The metastasis is very fast. So prognosis is poor. So treatment is different, prognosis is different. So clinically, it is seminoma and non-seminoma. That is seminomatous germ cell tumor and non-seminomatous germ cell tumor. Among the non-seminomatous germ cell tumor, whatever it is it Yolk Sac, embryoma, polyembryoma, choriocarcinoma, teratoma, doesn't matter because treatment of all of them is same and prognosis of all of them is same. And usually they are obtained as a mixed germ cell tumor. Okay, so that is the thing. So seminomatous and non-seminomatous. So this is the classification. I hope you all got it. So tell me the final classification, the 2 classification, the pathological and clinical classification of the testicular tumor. So pathologically, we divide them into 2 categories. What are the 2 categories? Germ cell tumor, they arise from the germ cell, and the sex cord stromal tumors. Sex cord stromal tumors. The sex cord stromal tumors are very simple. Only 3 are there. LSG. That's it. The germ cell tumor are 6 in number. YES, PCT. We further divide them into 2 categories clinically. Clinically, we divide them into seminomatous germ cell tumor and non-seminomatous germ cell tumor. In seminomatous germ cell tumor, among the 6, seminoma is coming. In non-seminomatous germ cell tumor, the remaining 5 are coming. That is YEPCT. So this is the final classification. So pathologically and clinically, we have divided them. As I told you, the differences between seminomatous germ cell tumor, which contains seminoma only, and the non-seminomatous germ cell tumor, which contains the remaining 5, that is YEPCT. See the differences between them. Seminoma is very radiosensitive, so radiotherapy is the treatment. These one are radio-resistant, so here we give surgery as the main treatment. Here the prognosis is better. Here the prognosis is poor. Here the prognosis is poor. It is spreading via lymph nodes. These are spreading via blood. These are large and confined to the testes only. They don't spread to other organs very frequently. These are small, but they spread to the other organs very frequently and they distort the testes. So you have to learn the differences. Now the most important difference between them is the tumor markers. The tumor markers are there. Let me tell you what does it mean. Now you can see here I'm drawing the diagram of a male. Now inside, in this male, I would like to show you the scrotum inside which the testicular tumor is there. So let me draw the scrotum here, and in the scrotum let me draw the testes. So these are the testes. Just suppose these are the testicles. Now in the testicles the tumor is there. If the seminoma is present in one of the testes, for example, this one is seminoma. If seminoma is present, now this is the blood vessel of this human, of this person, of this male, this is the blood vessel. So seminoma secrete. What does seminoma secrete? Which tumor markers in the blood? Seminoma secrete certain tumor markers in the blood. What is the name? So seminoma secrete 3 type of tumor markers: OCT, KIT, and PLAB. PLAB is placental, PL, placental alkaline phosphatase. So OCT, KIT, and PLAB, these are the proteins which are secreted by the seminoma into the blood. So if you collect, just suppose there is a male and having one of the testes enlarged and having one of the mass in one of the testes. So being a doctor, I am suspecting the person is having, this male is having seminoma. So to confirm that, we can do the biopsy, we can do the surgery. But for that, before that, we can collect the blood sample in a test tube and look for these markers. If these markers are elevated, our diagnosis will be supported by that. So this is known as tumor marker. But for example, this person is having any of the other non-seminomatous germ cell tumor. Non-seminomatous germ cell tumor, that is one of the 5, YEPCT. So what does they secrete in the blood? So this is the blood vessel. What does they secrete in the blood? They don't secrete OCT, KIT and PLAB. They secrete HCG and alpha-fetoprotein in the blood. So tumor markers are different of the seminoma and the non-seminoma. So just suppose there is a male in our clinic. In our clinic, there is a male and the male is complaining having a scrotal mass. In one of the testes, there is a mass and we can palpate the mass. On the ultrasonography also, there is a mass, the scrotal ultrasonography. So it is confirmed the person is having testicular tumor, but which one? So the best investigation we can do is the tumor marker. Collect the blood sample. So collect the blood sample in a test tube and look for these markers. If these are elevated, it's seminomatous. And if these are elevated, it is non-seminomatous. Among the non-seminomatous, we cannot differentiate them. Now we have to do the biopsy or we have to do the directly surgery and we have to see what is it. So that is the differences between them, the seminomatous germ cell tumor and non-seminomatous germ cell tumor. Coming on the etiological factors. Most important etiological factor is cryptorchidism. I hope you have watched my video on cryptorchidism. There is a separate video on that. What is cryptorchidism? The testes are formed in the abdomen, in the retroperitoneum, in the abdomen, and it descends gradually during the embryonic life, and at the term it is in the scrotum. And if there is a failure in the descent, it is known as cryptorchidism. The cryptorchid testes is at high risk of developing malignancies in future. So cryptorchidism is a higher risk factor. Sometimes the dysgenetic gonads are there, so they are at high risk of developing tumor in future. Genetic factors. Orchitis means inflammation of the testes. If the testes is inflamed, so it can have the malignancy. Trauma to the testes. Just suppose this male have an accident and there is a trauma to the testes. So in future, that male can have malignancy in that particular testes. Carcinogens, may be some pollution in the environment, some carcinogens, pesticides may be there. They can cause also the malignancies in the testes. Now coming on the clinical features. What are the clinical features in testicular tumor? There is gradual gonadal enlargement. So the male complaint there is a gradual gonadal enlargement in the scrotum. One of the testes is enlarging. There is a dragging sensation in one of the testes. And if it is metastatic, then multiple symptoms can occur due to the secondary symptoms, like person can have pain, lymphadenopathy, the inguinal lymph nodes are enlarged. Okay, hemoptysis can be there. In the urine, the blood can be there if it is coming to the bladder, and urinary obstruction can be there. So if it is metastatic, otherwise the gonadal enlargement and dragging sensation in the testes, these are the only two symptoms. But if metastatic, other symptoms can also occur. That is blood in the urine and hemoptysis. And hemoptysis if the lungs are also involved. So blood in the sputum and urinary bladder obstruction can occur. So these are the symptoms can occur. Coming on the spread, two type of spread is there. Lymphatic spread, hematogenous spread. Lymphatic spread is common in seminomatous and hematogenous spread is common in non-seminomatous germ cell tumor. Lymphatic spread occurs to retroperitoneal para-aortic lymph nodes, mediastinal lymph nodes and supraclavicular lymph nodes. And blood, via blood, it can go to the lung, liver, brain, bones. Most commonly it goes to the lung. So that is the spread. Now, out of the 6 YES, PCT, 3 are ultra important. We are not discussing all 6. Usually question come on 3 of them. And in your exam, if you are getting a long question also, out of the 6, you have to discuss 3. Yolk sac, seminoma and teratoma. These 3 we will discuss in detail. So first I will let you know seminoma. Among the non-seminoma, we will discuss 2, that is Yolk sac and teratoma. So you have to write the introduction of each of them, the gross of each of them, draw the microscopy of each of them. Don't write, never write the microscopy. Draw in your exam with a well-labeled diagram and write the tumor markers of each of them. So let's start with seminoma. Let's start with seminoma, the classical seminoma. What is the introduction? In these headings only we will carry. What's the introduction? It is the most common malignant tumor of the testes. So among YES, PCT, it is the most common. So it alone constitutes 45% of all the GCTs. So there are 6 GCTs, YES, PCT. So among the all 6, alone it constitutes 45% and the remaining 5 are constituting the 55%. It is equivalent to dysgerminoma in the female. It is the counterpart of the dysgerminoma in the female. In the female, the counterpart is dysgerminoma. In females, we don't have seminoma. In the females, in the ovaries, counterpart of the seminoma is known as dysgerminoma. So that is the introduction. So it is the most common malignant germ cell tumor in the male testes. That is the introduction. Grossly, you can see this is the testicle. This is the testes of a male having the seminoma. We have cut at the center and open it like an open book. So this is the testes. You can see we have given a cut at the center and open it like an open book structure. So you can see where is the tumor. You can see this is entire tumor. The tumor is replacing the entire testes. The tumor is replacing the entire testes. Tumor replace the entire testes, and the normal testes is shifted to the periphery. You can see this is the normal testes, this is the normal testes, and this is completely tumor. The tumor is yellowish and lobulated. The biggest word you have to highlight here is lobulated. The tumor is having a lobulated appearance. It's homogeneous, yellowish, grayish white, and lobulation is very important. You can appreciate the lobulation here. So write and highlight the word lobulated. You will get marks on writing that. Lobulated. So that is typical gross. It's a spotter image. It's a spotter. Coming on the microscopy, it's very peculiar. Now here we can appreciate the lobules. Where are the lobules in the microscopy? In the microscopy also, the tumor cells are arranged in lobules. First tell me the arrangement of the tumor cells. Here the tumor cells are arranged in lobules. Can you appreciate the lobules? Let me show you and highlight the lobules here. So you can see here I'm highlighting the lobules. These all are lobules. So lobules are formed by the stroma. This is all stroma. The stroma is forming the lobules. Now inside the lobules, let's take one cell. Let's take any one cell, any one tumor cell. And if you can zoom it, you can highlight it, zoom it, and see any one of the tumor cells. All of them are equal. So all the tumor cells are uniform. The lobules is filled with the tumor cells. Now see, they all are uniform. There is no pleomorphism. You can see all the tumor cells are looking same shape, same size. They are uniform. The cytoplasm is clear in them. You can see there's a nucleus at the center, the blue nucleus, but the cytoplasm is clear because the cytoplasm contains abundant of glycogen. Because of which it is clear, you have to write it. And there is a nucleus present at the center. Inside the nucleus, prominent dot-like structure is present, that is nucleoli. So you can see the nucleus, you can see the cytoplasm, and inside the nucleus, if you can see the dot is present, that is nucleoli. Nucleoli, sometimes one or two nucleoli are prominent. So that is typical tumor morphology. Now in the stroma, can you see the stroma? Please appreciate the stroma. Can you see in the stroma, what are these cells? Can you tell me what are these cells in the stroma? In the stroma, these cells are not tumor cells. Please see. These are not tumor cells. These are small blue color cells. You can see in the entire stroma, which is dividing it into lobules. In the stroma, lymphocytes are present, which is very peculiar feature of this tumor. It is known as stromal lymphocytic infiltration. Entire stroma have lymphocytes. So how to draw seminoma in your exam? So if I want to draw the seminoma histopathology in my exam, I will draw a box. Inside the box, what I will do? I will divide it into multiple small lobules with the help of the stroma. Like this, I'm dividing it into lobules. These are the lobules. I will label it as lobules. These are divided by stroma. This is my stroma. Now inside which I will draw the cells. I will draw the cells, the tumor cells. The tumor cells are, I will draw like this, the big cells having clear cytoplasm, having prominent nucleus, and inside the nucleus, I would like to draw the nucleoli, one or two prominent nucleoli. So this is how I will fill them completely. So this is the tumor cell. They are uniform. I will label them. They all are uniform cell. They have clear cytoplasm. They have central nucleus. They have prominent nucleoli. Now there is a peculiar way of describing any histopathology in pathology. Okay, so first you have to write the arrangement of the tumor cell. The arrangement is in lobules, number one. Now describe one cell. In one cell, first describe the size, then tell the cytoplasm, then tell the nucleus, then the nucleoli. So from outside to inside, start description. So first say the cell are uniform, they are big, they are large. Then say the cytoplasm is clear. Then say the nucleus is central and it's hyperchromatic, and in the nucleus there is a central nucleoli, prominent nucleoli. So this is how you describe. Now there is a peculiar feature that in the stroma you can see in the stroma, you can see the lymphocytes. So draw the lymphocytes in the stroma, small lymphocytes. In the entire stroma, try to draw the lymphocytic infiltration and label it and highlight it, which is very peculiar feature. So this is the microscopy of seminoma. I hope you all can draw it very easily. This is the microscopy. Okay, the same thing is shown to you here also. Here also you can see these are the lobules, appreciated. Inside the lobules, try to see the tumor cells. Try to see the tumor cells. The tumor cells are large. They are uniform. The cytoplasm is clear. The nucleus is central, and inside the nucleus you can see the dot-like structure, that is nucleoli. See, and see the stroma. Very important. See the stroma. Inside the stroma, see the lymphocytes. Very clearly you can appreciate inside the stroma, these all are lymphocytes. Appreciate it. So lymphocytic infiltration is very important inside the stroma. You will get marks on that. What are the tumor markers? I already told you the tumor markers of seminoma is OCT, KIT, and PLAP. What's the full form of PLAP? placental alkaline phosphatase. It is not acidic phosphatase. Here AFP and beta-HCG are not elevated. They are normal. So normal AFP and normal HCG, you have to write that. These are the tumor markers. Prognosis is very good. It is radiosensitive. So we will give radiotherapy as the treatment, and prognosis is better than other germ cell tumors. Okay. Now there is a variant of this seminoma, that is spermatocytic seminoma. Spermatocytic seminoma is a variant of normal classical seminoma which occurs in old age. It do not metastasize and having excellent prognosis. So it's a variant, you just learn it. Sometimes you can get a very short question on spermatocytic seminoma. You may be thinking, ma'am, what is it? So it's a variant of seminoma only which occurs in old age having excellent prognosis. Learn that only. We are done with seminoma. So you know it is the most common germ cell tumor. It alone constitutes 45%, and grossly it is replacing the entire testes, and it is lobulated in appearance. Microscopically, you have to draw it. You have to draw the entire tumor is divided into lobules with the help of stroma. Tumor cells are large, having central nucleus, prominent nucleoli, clear cytoplasm, and they are uniform. And the stroma contains the lymphocyte. You have to label that. Tumor markers, I told you, 3 tumor markers. OCT is elevated, KIT is elevated, and PLAB, placental alkaline phosphatase, is elevated. These 3 are elevated, but you have to write that beta-HCG and AFP, alpha-fetoprotein, they are normal. You have to write the negative finding also. Coming on the next one, Yolk Sac tumor. Let's start the Yolk Sac tumor. Yolk Sac tumor is also known as endodermal sinus tumor. Learn its other name. Sometime in your exam you get question on this name, so you don't recognize that it is the other name given to Yolk Sac tumor. So even on knowing the answer you can miss it. So don't do such silly mistake. So learn the other name of Yolk Sac tumor, endodermal sinus tumor, also known as orchioblastoma. So orchioblastoma or endodermal sinus tumor. It occurs in children. It's a tumor of children. It occurs under 4 years of age. So Yolk Sac tumor. Grossly, the tumor looks yellowish white with areas of necrosis and hemorrhage. So appreciate the areas of necrosis which are yellow in color here. Appreciate the areas of hemorrhage which are red in color. That is the gross. Coming on microscopy. This is the microscopy. First, always tell me the arrangement of the cell. Is it lobulated? No. Is it in sheets? No. Is it papillary? No. It is the reticular arrangement. The reticular is like sieve-like. Have you seen the sieve? Sieve. So it is like a sieve, small holes are there. So this arrangement is known as reticular arrangement, number 1. So tumor cells are arranged reticularly. The tumor cells are cuboidal cells. They are looking like a cube. They are not big polygonal clear cells like the seminoma. They are cuboidal cells. Now the hallmark feature here is Schiller-Duval body. There are 2 hallmark features. The first is Schiller-Duval body. What is Schiller-Duval body? What do you mean by Schiller-Duval body? Now see, this is a blood vessel at the center. At the center, there is a blood vessel around which the tumor cells are arranged. You can see these all are tumor cells. The tumor cells are forming the papillary projections. The papillary projections around the blood vessel. And this complete thing is known as Schiller-Duval body. So what is Schiller-Duval body? We have a blood vessel at the center and we have tumor cells arranged around it like this. This is the arrangement of the tumor cell around the blood vessel. We will draw the tumor cells over here. The tumor cells, the cuboidal tumor cells. The cuboidal tumor cells. So perivascular arrangement of the tumor cells around the blood vessel with papillary projection. It is known as Schiller-Duval body. Tumor cells form a papillary projection around the central blood vessel with a perivascular anaplastic germ cell. This is known as Schiller-Duval body. And if you highlight any of the tumor cell, here we cannot see it clearly. Let me show you another diagram. Inside the cytoplasm of the tumor cells, intracellularly, you will get hyaline globules. Let me show you. You can see any of the tumor cell. These are the tumor cells. You can see pink color cytoplasm. So the pink color globules are present in the cytoplasm. These are known as hyaline globules. So that is the thing. So how to draw the Yolk Sac tumor in your exam? Yolk Sac tumor. So in the Yolk Sac tumor, I would like to draw the Schiller-Duval body. I will draw a central blood vessel around which I will arrange the tumor cells like this in the papillary projections. So first I will draw the alignment and then I will draw the cuboidal tumor cells over it. These are the cuboidal tumor cells. Now this is Schiller-Duval body. Now inside the cytoplasm of these tumor cells, this is the nucleus. Inside the cytoplasm of these tumor cells, I would like to draw the globules in some of them. Not in all, but in some of them, I would like to draw the globule and I will label them as a hyaline globule. So this is Yolk Sac tumor. I hope you got it. Now the tumor marker here, alpha-fetoprotein is raised in 100% cases and alpha-1 antitrypsin. So alpha-fetoprotein and alpha-1 antitrypsin are elevated in Yolk Sac tumor. It is not OCT, KIT and PLAB. No, it is not like seminoma. So we are done with seminoma. We are done with Yolk Sac tumor. Coming on the last one, teratoma, and we will compare the 3. So coming on the last one, teratoma. Teratoma is a unique tumor. It arises from the totipotent cell. What are totipotent cell? Totipotent cell are undifferentiated cell. They can give rise to ectoderm, mesoderm, or endoderm. So basically, it's a tumor in which all the three components of the germ cell are present. So basically, it's a tumor. It can contain anything. You know, human body, the complete human body is made up of the three germ cells. That is ectoderm, mesoderm, and endoderm. During embryonic life, each organ is derived from one of the germ cell. So totipotent cell can give rise to any of the three germ cell. So these are the tumors which contain anything inside them. They are more common in children. Okay, now they see the cross is very typical, very peculiar. So you have to draw it in your exam. So this is the testes. Inside the testes, you can get anything of human body. So you can see the hairs. Here's the hairs inside the testes of this male. You can see the teeth is there. Yes, the teeth inside the testes. So hairs are there, teeth is there, bone is there, cartilage is there, brain is there, salivary gland is there, skin is there. You know, any tissue, because all the three germ cell derivatives can be present. So it is not fixed what will be present. So it's the thing, you know, in your university exam, most of the students draw anything. So it's a thing. If teratoma is asked in your exam, if you draw anything, I will give you full marks. If you draw anything, whatever you know, just draw it. Whatever, you will get full marks. So it can contain anything. So try to draw the things which are identifiable. If you draw the hairs, they are very peculiar. We can identify it. If you draw the teeth, cartilage, bone, we can identify it. Microscopically also draw anything. You can show the cartilage. You can show the smooth muscle. You can see here, this is the cartilage. Cartilage can be there, the glands can be there, the skin can be there, you know, the cells can be there. You can see smooth muscle cells can be there. So keratin can be there. It can be anything. So I'm saying you, if you draw anything, you will get marks. Teratoma. So that is the diagram of the teratoma. Tumor marker. Beta-HCG and AFP are raised, but in 50% of cases, not in 100 cases, like in Yolk Sac. So we are done. We are done with the three type of the tumors. The three important tumors: Seminoma, Yolk Sac, and Teratoma. Write the introduction of all three. Seminoma is the most common germ cell tumor. It alone constitutes 45%. Yolk Sac tumor, it is also known as endodermal sinus tumor or orchidoblastoma, and it is more common in children. Teratoma arises from totipotent cell. That's why it is having the derivatives of ectoderm, mesoderm, as well as endoderm. So that is the introduction. Now the gross of each of them. Please imagine the diagram. So this is the gross. Can you see? This one is Seminoma. Appreciate the lobulated appearance. Okay, this one is Yolk Sac tumor. Appreciate the areas of the necrosis and hemorrhage. And this one is teratoma, containing anything, especially the hairs, the teeth, the bone, the cartilage, the brain, the nervous tissue. It can be anything. Now see the microscopy of all of them. See the microscopy. See the microscopy of Seminoma. Seminoma, very peculiar. See the lobulated arrangement. See the tumor cells. And inside the stroma, appreciate the lymphocytic infiltration. Appreciate the lymphocytic infiltration. Okay. So please try to draw it. Don't write, draw it. In the Yolk Sac, don't forget the Schiller-Duval body. You know what is Schiller-Duval body, and the tumor cells contain the hyaline globules. And in the teratoma, draw anything, whatever you wish. You know, you can draw that. Tumor markers here in Seminoma: oct, kit, and plap is elevated. Okay, here alpha-1 antitrypsin and alpha-fetoprotein is elevated in 100% cases. Here also alpha-fetoprotein and HCG is elevated, but in 50% cases. So learn the tumor markers of all three. That's all about it. Now in your exam, if testicular tumor is coming as a long question, start with the classification, write down the two type of classification. You can combine them and draw one. Write down the risk factors, clinical features, spread, and gross and microscopy of these three. If individual short question is asked on Seminoma, Yolk Sac, and teratoma, you have to write that only. That's all about it. Thank you. Don't forget to look at the long question, short question, very short question, and MCQs of this topic, which is given in the question bank section as well as notes section. Thank you so much.